Welcome to AETCM, the emergency medicine channel. Today let us discuss about the use of antibiotics in emergency medicine department. We know that in most of the emergency rooms in India, it will be managed by ER doctors. Nighttime there may not be any specialist in this type of hospital. So knowledge about various drugs including antibiotics are very important for a ER physician who is doing individual ER duty. So we'll see what are the important aspects of starting antimicrobials in emergency room. Sometimes we can go wrong when we are selecting antibiotics, but that is okay. But a reasonable knowledge about antibiotics are very important for a ER doctor. So whenever we suspect an infection in emergency room, we know that 50% of the ER admissions will be due to infection. It can be due to simple fever, viral fevers, spontaneous bacterial peritonitis, meningitis, encephalitis, pneumonias, urinary tract infections. Various type of infections contribute nearly 50 to 60% of hospital admissions in emergency room in our country. So whenever we suspect infection, so that is a clinical suspicion. So once you suspect infection, we can diagnose infection with various emergency investigation modalities. One is complete blood count. We know that bacterial infection, WBC count can be elevated, except in very rare condition like endemic fever, WBC may not increase. Most of the viral fevers, lymphocytes will be slightly elevated. And neutropenia is classically seen in many viral infections. Urine routine is done in patients who is having urinary tract infection, and urine culture, blood culture, both should be done in patients who is having suspected infection, infective endocarditis, all these things. When we are taking blood culture, we have to be very careful because proper cleaning of the site is very important for getting a very good culture. Otherwise, lot of contaminations can occur during blood culture samples when we are taking the sample without any care. So it is not advisable to take blood culture in a very busy emergency room, because the staffs are very busy in emergency room. They have a lot of work, but to take a blood culture you need time and patience. So without time, if you are taking blood culture in a hurry, there is lot of contamination can occur. It can alter the results. Then if there is a pus, easy thing will be you can take a gram stain from that, and immediately you'll get the report of gram positive or gram negative organism. Procalcitonin is another important investigation which will tell you whether it is a bacterial infection or non-bacterial organism or a non-bacterial problem, like a patient who is having SLE can have pneumonia that may be due to activation of SLE. It may not be due to a bacterial infection. Some patients can have chemical pneumonia that is not due to infection, it is only an inflammatory process. So procalcitonin elevation will tell you whether there is a bacterial infection or not. Now initially we will see from top to bottom, we can see most common infection in emergency room will be upper respiratory tract infection. It can be in the throat, it can be in the sinuses, it can be in the ear like otitis. So many infections can occur in the upper respiratory tract. Most of these infections are due to viral infection. Like most of the infections in the throat, upper respiratory tract infections are viral, but it will be difficult to make a diagnosis in emergency room whether it is a viral or bacterial. With symptoms like rhinorrhea, nasal congestion, like sore throat, mostly it will be a viral infection. But patient who is having sore throat can have bacterial infection also. They can have streptococcal infection. They can have other type of bacterial infection in the throat. Clinically, a trained doctor who is an expert in infections can make out whether it's a bacterial infection or viral infection. But most of the ER doctors may not be able to fully diagnose whether it is a viral disease or bacterial disease. So many of the times we start antibiotics for these viral infections. We have to be very careful when we are treating this type of viral infection with antibiotic, especially amoxicillin, ampicillin, because one of the most important infection which can produce sore throat, cervical lymphadenopathies, infectious mononucleosis. In that type of patients, if we start amoxicillin, ampicillin, they can have severe rashes. So better to go for a mild antibiotic like azithromycin, 500 milligram T every day for 3 days, or doxycycline, 100 milligram BD for first day, 100 milligram OD for another 3-4 days. So that will not create any problem, that will not produce any resistance. So many advantages are there, dosing advantage is there, but if possible, try to avoid antibiotics in upper respiratory tract infection. In otitis media, if you are seeing first time, then gram positive coverage is very important. You can give amoxicillin 500 milligram TID or augmentin 625 milligram TID. If it is recurrently coming, go for a additional gram positive drug like levofloxacin or moxifloxacin. Same thing for sinusitis also. Acute sinusitis, gram positive coverage like amoxicillin or augmentin will be enough. But it is a chronic sinusitis, then better to go for levofloxacin, moxifloxacin, like that. So most of the upper respiratory tract infections are viral diseases. They don't require any antibiotic. If at all we want to give antibiotic, it has to be very safe antibiotic like doxycycline or azithromycin. Don't give amoxicillin for upper respiratory tract infection unless until you have a strong differential diagnosis of streptococcal sore throat. Otherwise, penicillin should be avoided in terms of infectious mononucleosis. Now, next important problem in emergency room can be pneumonia. You can see two X-rays here. One X-ray shows lobar pneumonia, other X-ray shows bronchopneumonia, bilateral diffused shadows in the both sides. Other side, you are getting only a homogeneous shadow in the right lower zone. So consolidations are mainly due to gram positive cocci, that is streptococcal pneumonia. Mainly we can use amoxicillin, augmentin, levofloxacin, moxifloxacin, all these things. But if it is the pneumonia is in the upper lobe, upper zone of the X-ray, then it can be due to Klebsiella, especially in patients who is having diabetes, alcohol and all. They may require antibiotics like levofloxacin, moxifloxacin, like that. Levofloxacin dose is 750 milligram once daily for 5 days. Moxifloxacin again for 100 milligram OD for 5 days. Augmentin 625 milligram TID for 5 to 7 days. Amoxicillin 500 milligram TID for 5 to 7 days. Whereas on the second X-ray, what you are seeing, bilateral diffuse shadows. If the short history is there, then it is mostly viral pneumonia. We have to start oseltamivir. Oseltamivir 75 milligram BD, that's an antiviral. Other viral infections, there is no major treatment, so you can just treat with oseltamivir with this type of infection. If there is a long-term history like 1 or 2 weeks cough, breathlessness, X-ray like that, then you have to think about atypical organism, atypical pneumonia. You have to go for drugs like azithromycin, clarithromycin, levofloxacin, moxifloxacin. They all cover atypical organism. If it is a longer duration like 1 month problem, then you have to think about tuberculosis. In that, proper investigation has to be done. Avoid unnecessary antibiotic initially. Wait for procalcitonin. Procalcitonin can be elevated in bacterial infection. It may be normal in tuberculosis or viral. Now, the best antibiotic in a mild infection who is not having any previous lung disease, azithromycin. So, azithromycin you can give oral or IV depending on the patient condition. Both are 500 milligram once daily for 3 to 5 days. It has got a post antibiotic effect. So 5 days if you are giving, or 3 days you are giving, another 5 to 7 days the post antibiotic effect will be there. So azithromycin you can see only in a strip, only 3 tablets will be there. So there is a dose 500 milligram once daily for 3 days. IV also 500 milligram once daily for 3 days. So if there is a comorbidity, like a patient is already having COPD, cystic fibrosis, bronchiectasis, malignancies, chronic diabetes, then there is a chance of gram negative organism which may come to the picture. So in that condition, better to go for levofloxacin or moxifloxacin. Levofloxacin 750 milligram OD, moxifloxacin 400 milligram OD, or you can even go for augmentin. Augmentin is 625 milligram TID. The same patient who are sick, same type of condition, the patient is sick, then go for IV injections. Dose is almost same. Only thing is augmentin will be 600 milligram IV TID or 1.2 gram IV BD. Now, if we are admitting the patient inside ICU, it is better to go for a higher antibiotic like levofloxacin or moxifloxacin. So basically, if the patient does not have a major lung disease in the past, levofloxacin or moxifloxacin are enough. But if the patient is having a previous lung disease like a severely damaged lung previously, now coming with a severe infection, it is always go for a higher antibiotic like ceftriaxone, tazobactam combination, cefepime, tazobactam combination, cefporazone, sulbactam combination, or piperacillin, tazobactam combination. So these drugs may be needed in a patient who is having a damaged lung with severe lung infection. If the patient is already on ventilator, we have to cover that type of organisms also, like cefporazone, sulbactam, piperacillin, tazobactam, with an MRSA coverage like vancomycin or linezolid may have to be given. Whatever it is, in routine patient who is having a lung infection, whatever may be the infection, levofloxacin or moxifloxacin are adequate. But remember, in our country, lot of tuberculosis patients are there. Many patients initially they can present with some infection, later they become tuberculosis or they already may be having tubercular bacilli inside them. So try to avoid this type of drugs, moxifloxacin, levofloxacin, as a first line drug for any doctor. But if you take Western standard textbooks, they always prefer to give levofloxacin or moxifloxacin. That is because they don't have tuberculosis in their country, so they can safely use this second line anti-TB drugs left and right there. But in our country, there is a chance of drug resistance after some times because we are using levofloxacin, moxifloxacin every day in our practice. So there is a high chance for resistance afterwards for this second line of drug. If you are thinking in that term, that line, then better to avoid this type of drugs. You can go for alternative drugs. There are a lot of alternative drugs comparing with levofloxacin, moxifloxacin action. Pseudomonas, if you are suspecting piperacillin, tazobactam will be an ideal drug. Sometimes we may have to give additional aminoglycoside also, like tobramycin can be given. Tobramycin nebulization can be given in patients, many patients who is having suspected pseudomonas infection. If there is an MRSA suspicion like bilateral lung infiltrates, cavitating lesions, patient is already admitted in another hospital, ventilated patients, then better to go for an MRSA coverage, vancomycin or linezolid can be given. Now, second most common problem in emergency room will be diarrhea. You know that diarrhea most of the time, like what we discussed in upper respiratory tract infection, it is mainly due to viral diseases, especially in children. So they don't require any antibiotic. They have to be given some antipyretics for fever. In children, we have to give zinc syrup or zinc capsule, oral rehydration solutions, IV fluids like ringer lactate. That's all enough. But in adult, sometimes we have to give resicerdrotil that reduces the secretions in the abdomen. If you are treating a patient who is having a non-infectious diarrhea, like after food immediately patient develops diarrhea, you are not suspecting any infection, there is no fever, then loperamide can be given. But better to avoid loperamide in the initial phase of the diarrhea because we may not be knowing whether it is a bacterial diarrhea or non-bacterial diarrhea. In bacterial diarrhea, we have to be very careful to give loperamide that can produce toxic megacolon. Now, ORS, zinc and all should be given in all patients who is having diarrhea, especially in children. Another important drug in that group is in bacterial diarrhea or travelase diarrhea is rifaximin. Rifaximin dose is either you can give some pharmacy 400 milligram tablets are available, TID can be given, or 550 milligram BD can be given. This is a non-absorbable antibiotic, rifaximin. You can see many doctors start ciprofloxacin tinidazole combination, ciprofloxacin metronidazole combination for simple diarrheas. So tinidazole or metronidazole is not a good drug in diarrhea. It should be given only if you are suspecting a parasite-induced diarrhea like amoebiasis, giardiasis, all these things. So initially itself, if you are starting ciprofloxacin tinidazole combination, it may cover everything. It may cover bacteria, it may cover parasites, but unnecessarily you may be giving a drug which produces very bad taste. Like if you are giving metronidazole or tinidazole, oral cavity you can get severe metallic taste. So in a patient who is having gastritis, this metallic taste itself may be problematic. So try to avoid this drug. You can give ciprofloxacin, you can give ofloxacin, both are in abdominal quinolones, or you can simply go for rifaximin. That's a non-absorbable antibiotic. And if you want to give an anti-parasite agents like metronidazole or tinidazole, there is a drug called as secnidazole. Secnidazole has got lesser adverse effects comparing with metronidazole. Metronidazole is a very cheap drug, but secnidazole is a costly drug. 2 gram stat can be given in most of the infections like giardiasis. Giardiasis is one condition that produces explosive diarrhea, like a patient will have severe gas and minimal diarrhea, whereas conditions like severe diarrhea, rice water stools may be a feature of cholera. So in cholera you can give doxycycline. Most of the antibiotics will work there also, but doxycycline or ciprofloxacin may be the ideal choice. Now all patients who is having diarrhea who is taking antibiotic must be given probiotics. Probiotics like lactobacillus will be very easily available. That should be given, because when we are having diarrhea and when we are taking antibiotics, the intestinal normal flora may destroy. So that can create some problem afterwards. So better to replace that by either you can take curd. Curd will be containing lot of lactobacillus, or we can take probiotic which contains this type of organism like lactobacillus or Saccharomyces. All these things we can take. Now, infective endocarditis is an infection of the cardiac valve. It can be a damaged valve, it can be a normal valve, it can be due to a replaced valve, it can be due to IV drug abuses. So the basic principle in treating this type of infective endocarditis, so the patient can have some murmurs, patient can have some chest pain, patient on auscultation you can get murmurs or like murmurs like regurgitation murmurs, and patient can have high degree fever with chills, rigors. So a patient who is having cardiac lesion, patient who is having drug abuse, IV drug abuse, patient is having a previous valvular disorder, valve replacement, coming with fever, always suspect infective endocarditis. Whether to treat or not, that is secondary. There are two types of infective endocarditis, subacute or acute. Acute will be highly symptomatic. So we have to start antibiotic. When we start antibiotic, before starting antibiotic, it is very important to take at least 3 or 4 blood cultures from different sites in different time. That is very important. We want to prove that there is a continuous bacterial flow from the heart valve to the systemic circulation throughout the day. So 3 samples from different sites, different time. Proper cleaning has to be done before taking these samples. So then we can start antibiotic. Basic principle behind antibiotic is, one, we have to cover the gram positive, second you have to cover gram negative. So you can see here the most important drugs here will be ceftriaxone. Ceftriaxone 2 gram IV BD or OD can be given. So ceftriaxone mainly covers gram negative organism. Then you have to give vancomycin, that covers gram positive organism including MRSA. So we are covering both gram positive or gram negative because we don't know what is the organism which is producing infective endocarditis. We have only taken blood culture. It will take another 48 hours to get the proper blood culture report. So we are giving only antibiotic, that is empirical choice. So you can give penicillin with ceftriaxone, penicillin with gentamicin, penicillin gram positive coverage, gentamicin gram negative coverage. Ceftriaxone with vancomycin, ceftriaxone gram negative, vancomycin gram positive with MRSA. So depending on the clinical scenario, you may add or reduce these antibiotics, but the basic principle is give a gram positive coverage, give a gram negative coverage, take blood culture, get the blood culture. If blood culture does not support your antibiotic, change it. So that is very important. Spontaneous bacterial peritonitis is a condition where the patient develops infection in the ascitic fluid especially in patients who is having chronic liver disease, hypoalbuminemia, all these things. Most of the time, this organism will be 85%, more than 85%, this organism will be gram negative, especially E. coli. So, any patient who is having chronic liver disease, ascites coming with altered behavior, hepatic encephalopathy, one of the common cause for triggering hepatic encephalopathy is infection, that too in the abdomen, that is spontaneous bacterial peritonitis. Main cause for that is gram negative organism E. coli. So, we will be covering for that E. coli. We can give ceftriaxone. That is one of the easiest available drug in emergency rooms, either ceftriaxone or cefotaxime. Both covers gram negative organism. So, cefotaxime 2 gram IV TID or BD can be given, or piperacillin tazobactam, ofloxacin, all cover gram negative organism. Piperacillin tazobactam covers both gram negative and gram positive organism. Ofloxacin covers mainly gram negative organism, some gram positive organism. Cefotaxime mainly gram negative, some gram positive organism. So, mainly we are targeting gram negative organism here. Now, skin infection, any skin infection, it can be a superficial skin infection, it can be a thrombophlebitis, it can be due to cellulitis. Various skin infection we can treat in emergency room. Basically, what we have to remember is, again, like previously we discussed in upper respiratory infection, bacterial infection, acute infection will be gram positive organism. But if it is a chronic infection, recurrent infection, there is a chance of gram negative organism. So, in an acute cellulitis or acute skin infection, always try to cover gram positive cocci, that is streptococcus. Recurrent infections or streptococcus and staphylococcus. Recurrent infection can be methicillin resistant staphylococcus or gram negative organism. So, that depends on that clinical criteria, you can select the antibiotic. Acute skin infection, somebody is coming to emergency room, or those who have a patient who is having an acute trauma and going to get infection in the coming days, then you can go for a gram positive coverage, like you can give augmentin. Augmentin covers most of the skin infection. You can give first generation cephalosporins, that also cover the skin infection. You can give azithromycin, that also covers the skin infection. But if it is a chronic infection, better to go for a gram negative coverage also. There you can give piperacillin tazobactam or other drugs which cover gram negative, and MRSA coverage has to be given. You can give drugs like vancomycin, linezolid, tigecycline, daptomycin, talavancin, all these things can cover gram positive MRSA, but main drug will be linezolid and vancomycin. Linezolid has got good coverage and it is available as oral tablets also, so that also can be given. Now, if the patient is having hypotension, shock, gram positive, suspected gram positive infection, we have to always think about toxic shock syndrome. There we will be using a drug which covers MRSA like vancomycin or linezolid, and you have to always give drugs which reduces the toxicity, that is clindamycin. Clindamycin has to be given in a patient who is having shock due to skin infection. And many patients who is having skin infection can be due to MSSA, methicillin susceptible Staphylococcus aureus. In that you can go for flucloxacillin, that is 1 gram IV for every 6th hourly has to be given. Instead of going for pristilin, penicillin or amoxicillin, we can even go for flucloxacin. That is a good drug for MSSA, methicillin susceptible Staphylococcus. So, Staphylococcus best drug is flucloxacillin. Streptococcus best drug will be amoxicillin, augmentin. MRSA best drug will be linezolid or vancomycin. Now, foot ulcers, again it is a difficult scenario. You have to see whether it's an acute infection, chronic infection. Acute infection, mostly you can treat drugs with like doxycycline or cephalexin, amoxicillin, clavulanic acid. But a chronic infection, it is always go for ticarcillin, clavulanic acid or piperacillin tazobactam. And you have to always add clindamycin along with your treatment regime, because sometimes patient may develop toxic shock syndrome because of this gram positive cocci infection. Urinary tract infection is another important problem in emergency room. We know that most of the urinary tract infection in female are asymptomatic. Asymptomatic means they are benign, they are not going to create any problem. But whereas in male, it is mainly due to a structural damage in the urinary tract. So when there is a structural damage, you have to give longer time of antibiotic. When there is a female urinary tract infection, short antibiotic regime is enough. So mostly we give norfloxacin 400 mg BD for simple urinary tract infection in female for 7 days, male for 14 days. Along with that, we have to take a urine culture and see what is a culture report. And if it is a recurrent urinary tract infection, you have to see what is a previous report available, what is a previous organism, whether it is the same organism in all culture report or a different organism in all previous culture report. Same organism means we are not able to eradicate the bacteria from the urinary tract, and that requires a longer treatment. But it's a different organism, it is coming from outside, it's an external source of infection. So according to the bacteria we can treat. So you can give norfloxacin, ofloxacin, levofloxacin. All quinolones are very useful in urinary tract infection. If it is a patient require admission like pyelonephritis and all, you have to go for higher antibiotic like ceftriaxone 1 gram BD, piperacillin tazobactam 3.5 or 4.125 gram BD, TID, ticarcillin clavulanic acid 3.1 gram TID. Like that, you can go for higher antibiotic. One important thing we have to remember is some patients may not require admissions, and in that patient fosfomycin is it's an old drug, but nowadays it is available. If the patient is having urinary tract infection, they are sick but does not require admission, you can give fosfomycin 3 gram stat every 2 days. You can repeat, and you can take the culture report and you can see what is happening to the patient. So you can avoid IV antibiotics if you are giving fosfomycin, but the cost of the fosfomycin is very high, so we have to be very careful. Another easily available and very cheap drug is sulfa drugs like Bactrim DS. Most of the antibiotics is a very good choice, but it's very cheap. But the only thing, some patients can develop severe skin rashes, Stevens-Johnson syndrome. So nowadays we are not routinely using this sulfa drugs, but they are very useful. They can be given in gram-negative infection. They have got some gram-positive coverage also. So very safely it can be given. And pregnancy, try to avoid fluoroquinolones. We can go for Augmentin, Cefixim. Like that, we can select drugs. Cefixim can be given in 200 mg orally BD. Augmentin can be given 625 TID. Meningitis, another important condition. You have to see the CSF finding, whether it is a bacterial meningitis, viral meningitis, tubercular meningitis, fungal meningitis. Bacterial meningitis will have high cell counts, the glucose will be low, proteins are elevated, gram stain is positive, and the cells are predominantly neutrophils. That is the important feature of bacterial meningitis. That is different in other types of meningitis. So once you diagnose meningitis, again what previously we have discussed, depending on the age, the organism may change. In adult patient, we always try to cover both gram-positive and gram-negative infections in the brain, empirically when we are treating. So you can select a gram-positive drug, you can select a gram-negative drug. Many doctors select crystalline penicillin with ceftriaxone, crystalline penicillin with gentamicin, ampicillin sulbactam, which also covers listeria, especially in an elderly individual, that can be given. If the patient is having severe meningitis, higher dose of meropenem can be given. 2 gram IV TID is the dose in meningitis, bacterial meningitis. But normally when we are starting in the emergency room, it has to be a drug which covers both gram positive and gram negative. It has to have very good penetration to CSF. So we can give crystalline penicillin with ceftriaxone. Both covers the meninges. Crystalline penicillin covers most of the capsulated gram positive organism. Ceftriaxone covers most of the gram negative organism. Or you can go for vancomycin with ceftriaxone. Vancomycin covers MRSA, gram positive capsulated organism. Ceftriaxone again covers gram negative organism. You can go for higher drug like meropenem. Meropenem covers most of the organism like gram positive and gram negative organism. only a bacteria which it may not cover, that is MRSA. MRSA, in normal clinical practice, there are a lot of bacteria are resistant to meropenem, but in a normal practice, MRSA will not be covered by this drug, that is meropenem. So according to that, we have to select the antibiotic, but basic idea is 1 gram positive coverage, 1 gram negative coverage. Now always try to give dexamethasone in a bacterial meningitis before giving the antibiotic. So before half an hour of antibiotic, you have to give dexamethasone. If the culture shows it's not a capsulated organism, then you can possibly discontinue the steroids. So dexamethasone has to be given in patients who is having suspected bacterial meningitis before giving antibiotic. Otherwise, this dead bacteria will produce severe inflammatory reaction inside the brain. Sometimes patient can deteriorate only with your antibiotic. Now, febrile neutropenia is another important problem in emergency room. So when we are having a good oncology department, you can get lot of febrile neutropenia patients. The treatment will be really difficult in an emergency room, because these patients require basically a reverse isolation or isolation, because they may come with simple infection, but what happens is in hospital or in emergency room, in a busy ICU or emergency room, they can get infection from various other patients. Even small infections can create very big problem in this type of patients. So reverse isolation is very important, and to prevent infection, you can go for a drug like ceftriaxone sulbactam. Ceftriaxone sulbactam or ceftazidime. Ceftazidime is a very useful drug because it can prevent Pseudomonas infection. So ceftazidime will be a drug which can prevent Pseudomonas type of infections in neutropenic patients. But once the patient develops infection, it is always better to go for a higher antibiotic like piperacillin tazobactam 4.5 gram TID, meropenem 1 gram TID, with or without MRSA coverage. So that is a common, these type of infections are very common in emergency room. But if you see each and every patient after getting culture reports, it may be something else. It will be very difficult to treat that type of patients in emergency room. So we have discussed about one of the important problem in emergency room, that is antibiotic. Many doctors who work in emergency room, they may not have very good knowledge about antibiotic, because for starting proper antibiotic, you need to know about the organism, you need to know about the infectious diseases, you need to know about the antibacterials, and you need to know the penetration of antibiotics to various areas. Like some areas antibiotics may not, routine antibiotics like patient who is having osteomyelitis, many antibiotics may not penetrate that area. Patient who is having meningitis, many antibiotics may not penetrate to that area. But when you are getting culture report, you are seeing that the culture shows response to that antibiotic. But when we read about the drug, we can know that this drug will not penetrate to that area. So in that condition, we should know how to change that antibiotic. But in emergency room, this is not possible. Whatever available knowledge, we have to utilize it, and we have to start the antibiotic, because delay in antibiotic is like an emergency. It's a problematic thing. Any infection is an emergency in our settings. So it is better to treat the antibiotic. Knowledge about antibiotics are very important. Knowledge about penetration of antibiotic to the various areas are very important. One more important thing is, many patients who is having severe sepsis can have hypoalbuminemia. What we should remember about this hypoalbuminemia is, albumin is one drug which can transport all these antibiotics to the specific areas. If albumin is not there in our blood, this whatever we inject, that may not go to the target site, and it will be useless. Like for example, a patient who is having severe sepsis, his albumin is only 1.5, and you are giving a drug like meropenem which costs very high, 3,000 rupees per dose. What is the use? It will not go to the target site, because there is no albumin to transport this drug to that specific area. This drug will simply go through the kidneys out. So that is also very important. Another important problem is dialysis. Many patients may require dialysis due to sepsis or renal failure. So Knowledge about dialysis is very important. Some drugs are dialysable, some drugs are not dialysable. Third one is creatinine clearance. Whenever we start antibiotic in any patient who is having kidney failure, initial dose will be same, but according to the creatinine levels we have to adjust the dose, otherwise patient may go to unnecessarily higher dose of antibiotics. Thank you.